Okay. Assalamualaikum and a very good evening to everyone. On behalf of the Malaysian Society of Infection Control and Infectious Diseases, MyICID, and the Special Interest Group in Antimicrobial Research and PKPD, MySPARK, I would like to warmly welcome all of you to tonight's webinar entitled Revolutionizing Antimicrobial Dose Optimization, Challenges, Breakthroughs, and Opportunities. I'm Fikree, everyone, pharmacist from University Malaya Medical Center, UMMC, and I'm honored to serve you as your moderator for this session. So before we begin, just a few brief announcements on our housekeeping announcements. So this session is being recorded and may be shared later for educational purposes. If you have any questions for the speakers, please type them into the dedicated Q&A at any time, and we will address them during the discussion segment at the end of all presentations. Kindly ensure your microphones are muted throughout the session to avoid background interruptions. Great, so let's move on. So we're going to talk about a bit of the background of why are we here for today. So the title is Revolutionizing Antimicrobial Dose Optimization. Antimicrobial dose optimization has indeed advanced far beyond the traditional one-size-fits-all paradigm. And amidst escalating antimicrobial resistance, evolving patient pathophysiology, and the emergence of sophisticated technologies, there is indeed a growing imperative to refine how do we individualize therapy at the bedside. Precision dosing, whether guided by therapeutic drug monitoring or TDM, or model-informed approaches, represents a pivotal step towards improving patients' outcomes, ensuring both efficacy and minimizing toxicity. Therefore, this evening, we are really proud and privileged to be joined by the three distinguished experts who will explore this continuum of precision dosing, from conventional pharmacokinetic principles and TDM strategies to advanced model-informed dosing, and lastly, the integration of the clinical software tools in real-world practice. Therefore, let's go to our first speaker. We have Dr. Jannatul Ain Jamal. She is the principal lecturer at the Faculty of Pharmacy in University Technology Mara, UiTM. Dr. Ain had completed her PhD in critical care pharmacy from the University of Queensland, focusing on beta-lactam pharmacokinetics during continuous hemofiltration, an area critical to dosing in critically ill patients. She has also brings over 20 years of clinical experience in the ICU and infectious diseases from major hospitals such as Hospital Pulau Pinang and Hospital Tengku Apuan Afzan. Her research interests include PKPD, personalized medicine, and critical care pharmacotherapy. Today, she will be sharing on optimizing dosing strategies without TDM. Dr. Ain, the floor is yours.
All right. Assalamualaikum and a very good afternoon to everyone. Thank you so much to Fikree for that very kind introduction and also exaggerate about me. So thank you as well to the organizer for inviting me. So just give me 1 or 2 minutes to share my slide. So are you able to see that in the presentation view?
Yes.
Fikree?
Yes.
All right. Okay. Thank you. All right. So again, good afternoon, everyone, and thank you for joining this webinar. So my name is Ain. I'm from the University Technology Mara, UiTM Malaysia. So today I'll be sharing on a very practical topic. So very historical components of precision dosing before my other two friends kick off it more advanced. All right. So my special focus of my talk today is actually about when the drug measurement is impossible or not available in our setting. The question is the one-size-fits-all dosing is enough for us. So before we go further, I think in many of our hospitals locally, okay, in our setting, we often have to make dosing decisions based on what we see at the bedside rather than what we can measure. This is especially true for common antibiotics, antimicrobial that we use in our settings, such as the beta-lactams. Okay, so the goal of my sharing today is actually to revisit the basics. Okay, to assist us while we waiting this the idea personalized dosing spread in our country. So that we can still do that, okay, but we need to understand the basics. So using clinical reasoning and also a simple parameters that are important that we need to know, that could help us in implement the individualized dosing as best as we can. Okay, so let's begin with this simple thought. Precision is not always measurable, but it is always meaningful, meaning that regardless that we have problem to measure that, but our patient has the right to receive the right dose. Okay, so we all know the basic principle of dosing optimizations. Okay, you have to give the right dose, the right drug, the right patient at the right time. But in infectious disease, I think the dosing is not stated. Okay, it changes with the patient's condition, right? The pathogen and also the drug characteristic. And antibiotic therapy, okay, dosing, it sits at the intersections of these three variables, and then each of them will influence the outcomes, okay? Okay, so PKPD, I think everyone knows that it helps us in understanding how much the drug is needed and reach the effective exposure at the infection site. However, applying this practice, usually it requires measurement, so which is the therapeutic drug monitoring, and that makes actually the challenge, okay, where's the challenge starts in our setting, right? So I would like to share, not only in Malaysia, in a few other similar healthcare systems, I think we face three major limitations. Okay, why we cannot do the therapeutic drug monitoring as our routine practice. I think the most challenge, the main challenge that we face is on the accessibility to do the therapeutic drug monitoring, especially beyond the traditional. Okay, not only focused to the traditional narrow therapeutic drugs, okay, such as the aminoglycoside, vancomycin. So to go something beyond to get for drug efficacy, such as to use it for the beta-lactam antibiotics. Okay, so we have a bit limitations to do that, okay, the tools to do that, okay, and some factors with certain drug availability. But the problem is with this limitation, we've also facing the same type of patients as what the other Western countries has. So we have the patients with high variability. For examples, we have the elderly patients, obese patients, critically ill patients, those complicated patients, where this group of patients, they respond to the drug treatments differently. And some data, this is very interesting. One data that I found, okay, that they did a survey among the Asian countries, okay, about the implementations of therapeutic drug monitoring, including one of the participants, okay, among the participants, they come from Malaysia, right? So the data overall shows that, okay, the finding shows that, okay, that there are barriers, okay, identified barriers such as funding. These are major barriers, okay, to implement the TDM in their practice. Funding, lack of cooperations, lack of expertise, meaning that doing this, to do the precision dosing, okay, individualized dosing, is something that is ideal. They want it, but it is often not feasible to do it, especially in certain settings, such as in the Asian countries. Okay, so what can we do when we can't measure the concentrations? So I think the most important right now is actually we go back to basic, and I think back to basic is also something that understanding this the basic, the fundamental of those individualizations. these are the things actually also the things the components that build up the population PK. Okay, the software or dosing for the populations. Okay, modeling. Okay, so in the circumstances where we are unable to have that proper, but if we just go to basic, understanding the structure that build up that things, and then try to optimize, okay, what we have, that could probably at least assist us or helping us in delivering the best personalized dosing to our patients with the limitations that we have. Okay, so going back to basic, by understanding the basic factors that influence dosing, as some of them that I have mentioned earlier. Okay, factors like age. Reading the patients. Okay, like age, body weight, the patient's organ functions. Okay, the renal functions, hepatic functions, the comorbidities. How those things can affect the drug pharmacokinetics. Okay, and then also identifying simplest reliable parameters. Okay, that are available in our setting, and then knows the practical hierarchy. For example, when you wanted to dose a patient, the first thing that you need to know is actually identifying the right estimations of body weight, and then knowing the urine output of the patients, and appreciate what you observe. What's behind excessive urine output that the patient showing to you, or patients without the urine output. So with a good knowledge, understanding what you observe, perhaps that could at least help us to individualize our dosing. All right. So these simple parameters actually they can guide for dose adjustment effectively if we interpret them wisely. Okay. All right, so this is just some of the examples, okay, when we estimating the GFR. So today I'm not going to debate or discuss about which estimation is the best to use, okay, equation, whether it is Cockcroft or MDRD, CKD, EPI. So I think each of them has some limitations, and perhaps they can be applicable to certain situations. So as a practitioner, I think you need to know the nature, okay, the history of the estimation. The equation that you wanted to use. For example, like Cockcroft and Gott. Okay, they most commonly use formula, but you have to remember it assumes the use of. It is derived from the creatinine in a patient with stable serum creatinine, and then it makes the assumptions that the creatinine decreases with one age or patients with greater weight, okay, without looking as a whole of body surface area. And then another estimations such as MDRD, okay, that derive from patients with predominantly non-diabetic CKD. So having says that, it means that it perhaps not, you cannot generalize the use of equation, but you can use them as a guide. To get the idea what's happened to your patients. But at the end of the day, actually, you have to look at the patient. Okay, for example, if a patient's urine output is dropping or rising dramatically, so that kind of change often tells you more than just a delay creatinine result. So meaning that is something's happening. So instead of you just looking at the numbers that that derive from your estimations, try to look at what's happened to your patients and see whether that's true, coming from a failure, or it's just because of something else that contribute to that, right? Okay, so the things here that I would like to highlight is actually some considerations. So meaning that when you use any estimations, when you use any, for example, equation, always try to look into, try know your patients, okay? Is it your patients, is elderly patients, obese patient, malnutrition, cacasic, or is there any potential, contributions from ethnicity or some body compositions? And then also remember that the limitations that we have, especially in our setting, that we use serum creatinine. And then if you look at, a lot of common guidelines, when they're referring to creatinine clearance, many of them now using urinary creatinine. So sometimes, they not easily can be translatable to our setting, because I think we are rarely measured the urinary creatinine. So be careful when you measure or when you observe numbers. So go back to your patient and see and try to understand that basic, okay? So here, another thing for consideration. So especially, I think, for the pharmacists, okay? So I think, even though, um, uh, the pharmacists, we don't diagnose patient, okay? Whether patients having AKI or CKD or acute kidney injury, but at least I think as a pharmacist, you need to know the spectrum of, patients who presented with acute kidney injury and then later on develop as moving to the CKD and then end-stage renal failure, or is it from the CKD reverting back to AKI or AKI normalized, so that you're aware of, the severity of the illness before you simply do a calculation or estimations of creatinine clearance, and immediately do the dose adjustment and make your recommendations to the prescriber. Okay, so I think you may find this reference is quite interesting. Okay, discussing about the acute kidney injury. Okay, the terminology, and as well as I think the limitations. Okay, when you observe the patient's urine output and serum creatinine, what are the cautions? Okay, that you have to be careful. And then do you really needs to, automatically defines that it is a kidney failure, or it is actually it's just a transient problem. Okay, so having said that, um, especially for the pharmacists, because pharmacists did a lot of dosing recommendation, asking the doctor, forcing the doctor to adjust the dose. You have to work closely with your prescriber, your doctors, and then get the perspective of what happened to your patients from the doctor, so that you can understand, well, is your patient is having, acute problem, transient problem because of the acute illness, or it's already developing for chronic problem, that yes, you have to consider that this is going to be something that permanent, that require, a proper adjustment. Okay, right. So I would like to share, I think this is very simple about meropenem, because we have been using meropenem. It's quite common. But the thing is, in Malaysia, I do not know if there is any hospitals that measured the meropenem in practice. Perhaps maybe in a research center, but I think it's not really well known about the concentration measurement, right, of meropenem. But we use them. And in other countries, outside from Malaysia, they use the meropenem, but they also measured the level. So meaning that the therapy is guided, okay, guided with the drug concentrations, and they can easily do the dose adjustment and achieve whatever the PKPD targets that they want. But unfortunately for us in Malaysia, we are unable to do that. But again, we know certain things about meropenem. For example, we know the basic characteristic about meropenem. For example, the video of distributions, the VD is about 0.4. So it tells us that meropenem is not, widely distributed in your body. So it remains mainly within the vascular. So it is hydrophilic, very minimal binding to plasma proteins, just about 2%, highly excreted through the kidney, about approximately 70%. The molecular weight is about 300 Dalton, so just slightly higher from the creatinine molecular size. So it means that, meropenem can easily be eliminated out if, let's say, there's a augmented clearance, okay, because of some reason on dialysis, or maybe there's some drainage or whatever, so there's a possibility that meropenem can be, being eliminated out, right? So if you look at the standard dosing recommendations, so the dose recommended is about 1 to 2 gram every 8 hours. And some recommendation, it suggests to give with and without loading dose of 1 to 2 grams. So they are quite safe drug, carbapenems, okay? So meaning that you can go, you can play around with the dose as long as it doesn't exceed. So in certain circumstances, you may need to consider that, not to easily adjust the dose, okay? Because I think this is common that we will see dosing adjustment guide, okay? In our in the reference, right? They give the creatinine clearance, but before we straight away, use that guide. So understand first the what you see, okay, the creatinine clearance that you calculate, okay, is it true a problem, or is just uh, temporary incidents, okay, for example, during the acute illness, okay, in septic shock, for example, early sepsis, okay, because we know that during those times, the pathophysiology of the patients is quite changed with all the fluid resuscitations, with the capillary leak syndrome. Of course, it will change the drug distribution. So it tells here that maybe you do not need to immediately adjust the dose. You can remain with the standard dosing as long as you don't exceed what has been recommended, okay? And then what you need to know is for how long, and then that will be based on your experience looking at the patient's response, okay? And then what kind of parameters, okay, that you need to monitor. So maybe you wanted to monitor the urine output, for example, the estimated creatinine clearance based on whatever calculations that you use, okay? So that you can have a close monitoring and then make a decision, the right decision later, all right? Okay, so this is just, another just sharing, okay? The dosing recommendation is quite established, but the thing is, sometimes in our setting, with our patients who are complex, we cannot easily, straight away change them. Unless we can measure the drug, then it will be quite easy, okay? So if let's say, your patient, especially in a severe condition, okay, severe sepsis, deep-seated infection, so you may need to depends also with the clinical parameters to assist you whether you can straight away follow the recommended dosing or do a little bit adjustment, all right? So understanding the changes, okay, during critical illness, what it can affect, especially the pharmacokinetics that relates to dosing, okay, the VD especially and the clearance, I think that will help you a lot, okay? So at least you can understand, whether estimate that the drug concentration will be a little bit low, or you will cause excessive, okay, especially in certain situations. So having said that, it's not all the time that you have to give the extra dose or alternative dosing, but in certain situations, especially the during severe infections or patients with deep-seated infections that may require a little bit large dosing, all right? So this is something that to recommend in practical, okay, that we can consider. For example, you can consider to start with a full loading dose, all right? You can continue with the standard dose and then put a time frame like 24 to 48 hours to monitor while you do a close monitoring on the urine output, serum creatinine, and as well as clinical response. And then once you observe stabilizations, that you can start to decide the proper maintenance dosing, and then identify the clinical parameters that to indicates improving, okay, response, okay. So those things, I think especially for the pharmacists, they have to work very close with your doctors so that you understand about your patient's progress, and you can assist your doctors to recommend a proper dosing approach, okay, when you cannot measure the concentration. So if you can measure, that should be not a problem, because you can just send the levels and then see and then do the dose adjustment, right? So I think in the absence of drug measurement, so to estimate clearance, of course, I think urine output is something that is important. However, I think you need to know, you need to appreciate the urine output presentations, okay, whether there's a significant urine output from the patient. So what does it tells you? If let's say it's exceeding certain limits, and then if let's say it is less than a certain limit, so what does it tells you? And in patients who presented with augmented renal clearance, the risk factor that patient may presented with augmented renal clearance, okay, so you have to appreciate the basics of that, because that will help you whether to trust, okay, this is urine output, and that the real urine output that you need to add on extra doses, or it's just like because of certain condition. For example, there's a diuretic, okay, that cause a urine pouring, or patients with a fluid overload because of resuscitations, all right, and then that will actually lead you to what you can, to decide, okay, whether you wanted to increase the dose or you just to maintain the dose, okay. And then I think another things that we need to understand when patient being put on circuit, okay, on dialysis. So especially when the patient is on continuous CRRT. So I think the clearance will be quite stable when they are on CRRT, but there's always a time that the CRT may be stopped, okay, because of clotting, or because of they move the patients because of for procedure, and sometimes restarting will take some time. So be careful, especially when you put high dosing in patients who are on CRT, because we always presume that you have a high intensity dialysis, that patients may require higher dose, but we tend to forget sometimes there will be a time that you have to stop the CRT because of many reasons. So that's the time where there's no clearance, okay. It will be depends on patients. And then whenever the patients return back to normal, okay, so return of residual renal function, so it will be another additional clearance to the patient. So if we're not aware of, or not, caution, then in certain circumstances, especially when you need to dose properly in patient with severe infection, if you're not aware of that, you might lead the patients to receive suboptimal dosing, okay. Intermittent dosing will be a little bit headache, because in practical, the dialysis can start at any time depending on the availability. So as a pharmacist, especially know at least the changes, okay, or when they usually start their intermittent dialysis, and then try to adapt with that situation, so that you don't sometimes we might miss, for example, we tell the nurse to dose the patients after the dialysis. And then if the dialysis happen, to be over the weekend or at night, you might miss that. And then patients might left, without dosing. So try to make something that a bit flexible, and then considering that, understanding what kind of dialysis patient will be in, and then based on some of the established data, try to estimate, what possible percentage of drug will be removed. Is it going to be so significant, or is it enough with just to have a little bit additional dose, like one single loading dose initially, so that it can supplement the dose, the potential dosing loss during the dialysis. Okay, so try to make something that is a bit practical. Okay. All right, so weight consideration is another things that I think in basic that's very important. So knows when to use the actual body weight, the ideal body weight, adjusted body weight, or dosing weight. Every drugs might have a different requirements, and then different patients also might have different considerations, especially like the obese patients or patients that is underweight. Okay, so be careful, especially when dosing these two type of patients. Okay, so this is things that you might find from any references. Okay, the recommendation, of course, the best is actually couple them with measurement. Okay, TDM. But if you're unable to do that, at least you can estimate the appropriate creatinine clearance, and then use proper dosing estimator. So at least you can deliver the right dosing to your patients, right? So again, always caution with certain clinical problems that can cause significant changes to your patients, such as burn injury, in the presence of capillary leaks, such as during the sepsis, patient who receive massive fluid resuscitation because, distribution of drugs can change, and also the albumin, okay, because this is just to show about the volume of distribution that changes, especially in patients with burn injury. So they might have quite significant changes in the volume of distribution for certain drugs, especially the hydrophilic drugs. So you might consider to give extra additional doses, especially in patients with burn injury. And then this is with patients, when you're handling drugs with high protein binding. So whenever you have patients with hypoalbuminemia, so you need to know that that the portions of the free drug concentration will be high. So is there any possibility that the patient might be excessively exposed to more free drug concentrations, or the patients might excessively exposed to higher clearance of the free drugs? Okay, so you have to know that potential situation, so that you know which one, whether to adjust the dose to give more frequent dose, or you have to reduce the dose, right? So putting all together, perhaps some considerations, in places where with limited resources setting, especially, drug measurement, make sure that you estimate the weight properly. Okay, knows weight estimator to use. Okay, whether you wanted to use the actual or ideal or adjusted, assess the urine output, and then knows appreciate the urine output, whether it is there any contributions from the diuretics, or is the patients having a massive fluid resuscitation. Estimate the creatinine clearance based on whatever equation that you wanted to use, but make sure that you're aware of the limitations, okay, and of the equations. Apply any drug specific recommendation if there is any, and monitor the response. Okay, knows what to monitor. And then here I would like to emphasize that in the absence of, we cannot measure the drugs, clinical judgment and proper monitoring is important. And then applying these steps, actually it possibly can make the dose individualization achievable even without the TDM. So as a summary, is one size fits all enough? Of course, I think it's clearly not. So in critically ill patients and then or patients with renal failure, obesity, or burns, they are all required special dosing, okay, tailored approaches. So even when we can measure the concentrations, actually our clinical judgment, understanding of PKPD and bedside assessment can still drive the precision dosing. Again, precision isn't always measurable, but for our patient, it is always meaningful. I think that's all from me. Thank you.
Well, thank you, Dr. Ain, for that insightful and clinically grounded presentation. We appreciate that. And to all the participants, you are welcome to put in your questions in the dedicated Q&A at the menu, and we're going to sort all the questions at the end of the session. We'll now moving on to our next speaker. So our next speaker is Dr. Nusaibah Abdul Rahim. She's currently the Dean of the Faculty of Pharmacy from University Malaya. So Dr. Nusaibah holds a PhD from Monash University, Australia, with expertise spanning antimicrobial PKPD, digital health, pharmacometrics, and molecular pharmacology. Her research includes innovative studies integrating multi-omics, genome-scale metabolic modeling, and antibiotic combination strategies against multi-drug resistant gram-negative bacteria. She has also published in high-impact journals such as CPT, Pharmacometrics and System Pharmacology, Frontiers in Pharmacology, and Journal of Antibiotics. So for today, she will present on model-informed precision dosing, MIPD in Malaysia. So this is a very interesting topic. With that, Dr. Nusaibah, we invite you to begin.
Thank you so much, Fikree. I'll just share my slides. Okay, yeah, thank you again so much. Thank you also to MyICID, MySPARK for organizing this webinar. Thanks to everyone who's joined in on a weeknight. Okay, so I'm Nusaibah. I'll be talking a little bit about MIPD in Malaysia. Where are we at? How do we, what are the gaps and barriers, and how do we get MIPD as part of our, workflow in practice? Okay, so with that, just to start off with and share the outline of my talk, I've decided to break it into 3 parts. So starting off, let's talk about MIPD. What is it all about? So just a bit of background, touch on pharmacometrics and TDM, and then touch on Bayesian method, as well as the tools that are already available out there. And then we'll move on to seeing, the landscape in Malaysia in terms of what's happening in research and what's happening in practice. And then, as mentioned, talk about the gaps and, some actions that we can potentially do in terms of implementing MIPD as part of our practice. And then I'll just end the talk by doing a bit of sharing from the things that we've done from our research group. Okay, so to start off with background on pharmacometrics. Okay. We always hear about pharmacometrics, right? So when we talk about pharmacometrics, we hear about pharmacokinetics, we hear about pharmacodynamics, PK/PD, we hear pop PK models. So what is it all about? So basically, pharmacometrics is basically the science that interprets and describes pharmacology in a quantitative manner. And why we need pharmacometrics? Because it helps us in terms of supporting the whole process of drug development. So with drug development, you might hear another term, MIDD, as opposed to MIPD. So MIDD stands for Model-Informed Drug Development. But then when we're in practice, we talk more about MIPD, Model-Informed Precision Dosing. So it's really crucial in terms of, with clinical trials, using these models, PK/PD models, to even get the right dose, especially when we talk about first-in-human trials and all of that. So pharmacometrics is basically just that science that, as mentioned, just quantifies, all of this pharmacology models. So I just wanted to highlight, because when we talk about pharmacometrics and we talk about MIPD, the relation is basically pharmacometrics is the umbrella term. And then when we talk about MIPD, it's basically applying these pharmacometrics into a clinical setting and to obtain that precise dose. Okay, so a bit on TDM. Okay, so I think when we talk about MIPD and TDM, we're not talking about replacing TDM. Okay, so TDM is very important. Of course, we talk about therapeutic drug monitoring. And in this context, we're talking about antibiotics, the ones with narrow therapeutic windows. So we often talk about vancomycin, we talk about aminoglycosides. So just wanted to highlight what are the differences, what do we get with TDM and what could we get with MIPD, and why we want to move or, hope to want to move towards MIPD. Okay, so just looking at this figure here by Agama et al. So you can see clearly there are three plots here. Okay, so we'll start with the first one, the red one. So the one dose fits all, you give the standard dose and then it might not even, be in the level that we want in terms of that therapeutic window, right? And then with TDM, luckily, when we start the dose, and then we can actually adjust it after we get that, when we do the PK sample. So that's the blue curve here that we see. So you start with the standard dose, and then we wait till steady state, and then we do the sample, and then we check, is it above, is it below? We don't want it too high, we don't want it too low, and then we adjust the dose, and then hopefully then the concentration, will get to the place that we want it to be. So again, that's great because we do TDM because of that, variability between patients, and we want to personalize dosing. However, because we need to wait until we reach steady state, it means that our patients might be receiving suboptimal dosing while we wait for that steady state to happen. So because of that, with MIPD, what we hope is to get quicker target attainments. So you can see now with the one in green here, MIPD, so we give the individualized first dose from the get-go, we give an individualized dose, and then it straight away hopefully then gives a precise dose so that the patient already achieves that PK/PD target and that we hope to attain. So basically, MIPD is not replacing TDM. It's part of the TDM work flow. So you have TDM because you still have to do therapeutic drug monitoring in terms of getting those samples, but then getting it at a quicker stage. So here, just showing another figure that's adapted from Wicha et al. So the difference again with TDM and MIPD is that with the sampling, you don't have to wait for steady state. So with MIPD, we hope to then attain, quicker, target attainments. So another thing that you'll hear with TDM and MIPD, with MIPD, the word, the buzzword that you'll hear is Bayesian. So basically, it's now using this, statistical, mathematical framework in order to then, come up with that precise dose. So if we compare here, this is a figure by Mick and Mayer et al. So again, with conventional TDM, when you get the concentration, you compare it with the target range. But with MIPD, you basically use that input and then carry out a Bayesian estimation of the PK parameters, which then you simulate various dosing regimens to see to look at the exposure, and then from there look at which one would then get that target that we hope to achieve. So that's basically what MIPD is all about when we compare it with the conventional TDM. So in summary, so MIPD, as mentioned, it basically combines POP PK models, patient data, and Bayesian forecasting. So again, the word here, Bayesian forecasting, in order to individualize dosing. So we use TDM as well as these models to predict, the precise dose in order to achieve the PK/PD targets. Again, it's not just for this webinar, we're just talking about antimicrobials, but just do know that MIPD, of course, is not limited to just antimicrobials. Similar to TDM, we do TDM for other, not just for antibiotics. So with MIPD as well, you would also see it in, say, oncology as well as immunosuppressants. But for in this case, we're talking more about vancomycin, aminoglycosides with using MIPD. Okay, so the word that I mentioned, this Bayesian method, again, it's a statistical approach where we talk about two things here. We have a priori and a posteriori. So basically, it has prior information, and then whenever it gets new information, it feeds it into this POP PK model, and then with that we get the MIPD in order to get these PK parameters that are individual to the patient. And as mentioned, we simulate all of the different dosing regimens to get the exposure that would then attain that PK/PD target. Okay, so this is just to show the cycle of what we mean by MIPD using that Bayesian POP PK modeling. So MIPD came about, it's been a while, it's been around for a while, but one of the main ones was with vancomycin. So the guideline on vancomycin talked about how when we talk about, AUC, the preferred approach is actually by using Bayesian software programs. So with that, how are clinicians going to then, talk about maths, talk about stats and all of that? So basically, this is where we need softwares and tools that would enable clinicians to use it. So basically user-friendly tools where we can use the tools that, already incorporates these Bayesian, models, as in Bayesian POP PK, in order to then get the precise dose. So with that now, moving, currently MIPD is being implemented, okay, in the West, and in Asia as well, we see it. It's being implemented in Japan, in Korea, in China, and it's also coming up now even in Southeast Asia. So Vietnam is one of the countries that is also implementing MIPD. So here I'm just sharing some articles that show, MIPD implementation. Okay, so as mentioned, what we need are MIPD tools, right? So not to say that they're not available. This was a review in 2020 by Kantasir Pirtak, and we can already see that there's already 10 here. Okay, so this was in 2020. Okay, so of course, there's some differences in terms of the different tools that are available. Cost is also another aspect that people look into. Can these hospitals afford subscribing to these tools? Okay, so just highlighting that these MIPD tools are available. And so what's the current landscape in Malaysia? So as mentioned, MIPD is not part of our current TDM process workflow, right? So in practice, we do TDM, okay? So of course, we do TDM for vancomycin, aminoglycosides, and some antifungals, but we don't have local MIPD tools, meaning to say, when we look at this slide, these MIPD tools, when you look at the country, none are like, Malaysian MIPD tools, okay? So one, we don't have local MIPD tools, but the thing about MIPD is that we want to use the POP PK models that's relevant to our patients. Okay, so it's all about having the, developing POP PK models that actually looks at Malaysian population. Okay, so that's also lacking. Okay, so basically here, as mentioned in research, that's the area that, people are working on in terms of, hey, we need to develop these POP PK models so that we can feed it in, and then we can only then apply and use these MIPD tools. Okay, so there is growing interest for sure in pharmacometrics. Okay, and we do see research on MIPD related projects these days. So the expertise that we need, again, we need pharmacometricians, as mentioned in the first slide in terms of the background. Pharmacometrics, we need these skills, the skill set. So in Malaysia as well, we do have PAGMIS, so that's the Malaysian Population Approach Group. So we do have pharmacometricians, but moving forward, it's still a gap in a sense that we need more of that, right? So we need more pharmacometricians, we need, more POP PK models. And the other gap is the actual infrastructure that we have in our Malaysian hospitals, right? So EMR, so when we talk about MIPD tools, at the end of the day, it'll need to be integrated with the EMR. So whether or not that's doable, integrating that MIPD tool with our EMR. And then again, as mentioned, currently we do not have access to these MIPD tools. So the other thing that we would need to look at is how to go about, supporting, say the subscription of these tools, or, coming up with tools that really truly do capture our population. So these actions, basically, they just reiterate based on the gaps that we talked about in terms of, we need to develop these POP PK models. We need more capacity building in terms of having pharmacometricians. We need to strengthen our EMR, looking into how to integrate it as part of that workflow. And at the end of the day, when we talk about MIPD, we will have to also do health economic studies just to look at the cost effectiveness as well. Okay, so now, just before I end, I just wanted to share, as mentioned, about the things that we've done at our research group. So at Malaya Translational and Clinical Pharmacometrics Group, which was established in 2022, so this is directed by me along with our co-director, Dr. Yue Lin. So he's our lead pharmacometrician. As part of this research group, we also have another arm, so we don't just look at pharmacometrics, but we also look at bioinformatics. And then just listed some of our, members here, along with our PG students, who's been working on these MIPD projects as well. So these are the areas that we cover: pharmacometrics, antimicrobial PK/PD, ISID. So what happened was that we got PRGS. So we tried to, go ahead and then, as mentioned, we need an MIPD tool. So we thought, like, how do we go about it? So we applied for PRGS in terms of coming up with a prototype. We successfully got this grant in order to develop this model-informed precision dosing tool based on local Malaysian population. Okay, so I'll just share. Of course, this is all. We're now talking about the prototype, but I just wanted to share when we talk about top dose, which stands for Therapy Optimization with Precision Dose Tool. We started off with the web-based, the desktop app. Okay, so all of this involves skills to do with R, non-mem, and using Shiny. Okay, so we basically looking at that, as mentioned, we're talking about the Bayesian POP-PK modeling. We need to do that literature review of all the POP-PK models and then validate it with our own internal data sets from our hospitals. So that involves data collection, and then we develop the MIPD. And then, as mentioned, we need R and non-mem skills. And then we use a Shiny interface, in order to create that tool. So we started off with the desktop version, the web-based version. So this is just to show what it looks like. So basically, you'll be able to select the model that you want. You can put the relevant covariates based on that model, and then basically then calculate, the doses. So, and then with this, now we've also moved on to the mobile app as well. So looking at whether or not we can convert this also to a mobile app. So this is something that, we're doing in terms of the prototype. So I just thought I'd share a bit, but again, it's still a long journey, of course, because we're still at the prototype stage, just an alpha prototype. We hope to move towards our beta and then moving on to a minimum viable product. But just thought of sharing in terms of how to go about, coming up with an MIPD tool. So at the end of the day, we do need to develop those POP-PK models, and then in order to then, put it in, our tool and software. Okay, so I think that's that for the sharing part. I thought before I ended, I know we want, we're talking about where are we at in Malaysia. We talk about TDM, and then, hopefully we'll see MIPD in practice. But in terms of future direction, so MIPD, as mentioned, is already being implemented elsewhere. And what you see is that the future would also be, implementing and incorporating AI and ML. So I just highlighted here an example, a webinar from ISAC Early Career Working Group, because it talked about MIPD in a pediatric population in China, and they already incorporate AI and ML. So if you were interested in seeing how that's done, just thought I'd just put that there. And then the other thing is precision medicine. So we talk about, input, right, and output. So for now, we're only actually just talking about MIPD based on PK. But moving forward, when we move towards precision medicine, then we can also have further input, right? So in terms of biomarkers, where, if it affects, the PK/PD of that drug. So that'll be interesting to see. So again, just highlighting the main future directions of MIPD. So not just like MIPD coming here, in Malaysia, but also like where is it heading? So as mentioned, AI, ML, as well as, it'll be part of that whole precision medicine ecosystem as well. All right, so I think that's all from me. So yeah, I'll end it now. Yeah, thank you so much.
Okay, thank you so much, Dr. Nusaibah. That was indeed an excellent overview, which I find very comprehensive and very eye-opening on MIPD and how we Malaysians here especially can move forward and can start, tiptoeing on how can we actually improve our precision dosing. And I'm sure like our participants here have like a lot of questions. You can unravel your curiosity more to know about MIPD. You can put your questions in the Q&A, and at the end, we're going to address some of the good questions which can be benefited for everyone. All right, time to go for our final speaker. She is a special guest that we have from Australia. So Dr. Amy Legg. She is an infectious diseases and antimicrobial stewardship pharmacist at the Royal Brisbane and Women's Hospital. Dr. Amy has extensive experience across Australia and internationally, including contributions to therapeutic guidelines and research in antimicrobial stewardship and nephrotoxicity. She has just recently completed her PhD at Charles Darwin University, where she looked into antibiotic-induced kidney injury, and the thesis was marked as a top 5% thesis reviewed. She has also involved in clinical research trials, vancomycin AUC calculator development, and national AMS advisory roles. So without further ado, I would like to invite Dr. Amy to talk about practical applications of dosing software. Dr. Amy, the session is yours.
Thank you so much. It's such a pleasure to be here. I feel really honored that you've asked me to present, so thank you so much. Just get my slides set up. We'll get going. So as mentioned, I work as a clinical pharmacist in Australia, and my research interests are really strongly related to kidneys and particularly vancomycin. And in my work as a researcher, I've also done a lot of dosing software and then have integrated it into my clinical work as well. So I'm going to try and keep this pretty practical. I'm just going to hide that. So my setting is in Royal Brisbane Hospital in Brisbane, which is in Queensland, and a lot of people know where that is because some of the panelists have lived and worked there. So it's not that unusual, not that far away. And the Royal Brisbane Hospital is, by Australian standards, quite a big hospital. It's about 1,000 beds. We've got a helipad up here, and then 2 buildings at the front, another building at the back. And then next door to the Royal Brisbane, we're very lucky to have 3 research institutes that foster collaborations between the clinical staff at the hospital and then research staff. And one of the levels of those research institutes is really filled with pharmacometricians, exactly as we were just hearing about. So in my hospital in the Royal Brisbane, this is essentially our model of care with therapeutic drug monitoring. And I just want to talk about how we've integrated dosing software into that. So we obviously always start with the patient, identifying a patient who's appropriate for therapeutic drug monitoring. That's step 1 in the middle of the graph. The second step is to ideally have a defined exposure target. So thinking about what our minimum target would be, and then our maximum target, which would be related often to toxicity. We prioritise taking samples early in therapy when the risk of mortality is highest, potentially for our septic patients, although you could argue that there's multiple stages throughout the infectious journey where TDM is important. We are very lucky here at the Royal Brisbane to have same-day TDM for a lot of our beta-lactams, vancomycin, voriconazole, and that makes it a lot easier. And then essentially we integrate dosing software into the clinical interpretation of the therapeutic drug monitoring result. Then we adjust the dose prescription and then recheck if appropriate. And really thinking, based on the previous 2 speakers, I certainly don't think that you need to be doing TDM in every patient. There's a lot of, just understanding the drug, understanding the patient, and being able to make informed decisions. And what we're really talking about here in my talk is the real pointy end of therapeutic drug monitoring and precision dosing. But that's certainly not to say that if you don't have it, that you can't still do excellent precision dosing, based on what we've already heard. I will just really quickly talk about our TDM service. So we do have a beta-lactam TDM service in Brisbane. It started off with 12 beta-lactams where they were measured by total concentrations, and then we were really lucky to be able to support the lab to come up with unbound concentrations. So now we are able to get unbound concentrations of the majority of beta-lactams within 24 hours of taking a sample. And so once you start doing something like this, everyone gets on board and the number of people requesting samples increases and increases. So these are just the number of samples that were requested from the pathology in Queensland between 2010 and 2020. And you can see at the start in 2020, there was about 400 samples over the course of the year, and they were predominantly just from the Royal Brisbane. And then with each year, the number of samples increased, a bit of a dip in 2015. And the other thing you can see is that the number of samples from the Royal Brisbane actually decreased. And I definitely was reflecting on that recently, where the more I do TDM and dosing software, I think the more sometimes you feel comfortable not doing it as well, because you get very familiar with the type of patients and what they need. So it's a really useful thing to have, and it really helps your learning. But then actually over the course of many years, sometimes you need to use it less because you sort of, do human learning and work out the trends in your patients. So we have access to therapeutic drug monitoring for all of these. So the ones that are in the first two columns in the table are run daily from Monday to Saturday. So we, particularly in our ICU patients, when we're worried about augmented renal clearance and low concentrations, we do a lot of piperacillin tazobactam, we do meropenem, we do flucloxacillin, particularly in the setting of staphylococcal infections. We do things like voriconazole quite routinely. We wouldn't do that early in therapy. We normally wait till about day 5. And then there are some drugs that actually we do more if we're worried about toxicity. So cefepime, we often do more, in the setting of renal impairment when we're worried about high concentrations. And then there are some drugs that we're just run once a week that we do have some flexibility, but that's been really useful as well, particularly for things like linezolid and some of the antimicrobial drugs. With our therapeutic drug monitoring program, we did write a guideline, just if you sort of are looking for resources. This doesn't really touch on dosing software, but it does. It's freely available on the internet if you just search MIPD TDM guideline, and it just goes through, a lot of drugs and what, as a consensus from the Royal Brisbane with our PK/PD experts, we've put minimum and maximum concentrations for a lot of the drugs that are less frequently done, just if you are implementing TDM. And what we've also done is try to think about who needs it. So it's really the patients that have some sort of altered pharmacokinetics. And again, just thinking about the talks we've had tonight, you can still make good decisions in the absence of TDM, but it's, if you've got it, which patients could use it, it's going to be those patients who've got altered PK where you're worried about high or low levels, but also difficult to treat pathogens, difficult to treat site of infections, where it's less about the patient and what they're doing to the drug and more about making sure that you are actually killing the pathogen that you're going for. All right, so now I'll get into some cases. So the next bit will be just some cases we've had in practice where we've used dosing software to help with precision dosing and dose optimization. We use a lot of IDODS, which is, I actually think it's a subscription now. For a long time it was free, but now I think it's recently gone to a subscription. And it's coordinated by a guy out of the US. And it's individually designed optimum dosing strategies. It's quite easy to use, but you do need to do a little bit of training to understand it. And this was some dosing software and TDM we did for a patient in our ICU who was a 45-year-old, 175 centimeters tall, 85 kilo male. He had an ESBL E. coli in blood for an intra-abdominal source, had his gallbladder out, but it had perforated and there was contamination throughout his body, and he was a little bit immunosuppressed and so got an ESBL E. coli. He didn't have any kidney impairment. He had a creatinine of 56. And then again, we're all talking about how to get the most accurate creatinine clearance. Should you be using actual body weight, ideal body weight? Should you be using CKD epi or creatinine clearance? My personal preference is to still use Cochrane Gold for drug dosing and to be thinking about CKD epi as a marker of sort of kidney filtration. But I do still tend to use actual body weight unless they're obese with Cochrane Gold. And anyway, so if you use ClinCalc these days, you can get a list of all the different creatinine clearances that would have resulted from all the different equations and the different body size descriptors. So this patient's creatinine clearance is somewhere between 126 and 152 mils per minute. And he was quite sick. He was in the ICU requiring presses. And so this is a patient where I am thinking, you know, this is really high clearance for a renally cleared drug with low protein binding. I'm worried about low concentrations for a difficult to treat pathogen. So empirically, we dosed aggressively, where we gave intravenous meropenem 6 hourly, but we only achieved a concentration of 1.7 milligram per litre on day 2. So we use the UCAS breakpoints, and so meropenem susceptible. Ideally, you want to have a trough concentration of 2 or above, which will give you 100% of time above the MIC. And just a reminder, the concentration in this setting is unbound because we get unbound concentration. So at the end of the dosing interval, this was a trough concentration, the patient had dropped below the MIC. So we were worried that for our ICU patient, we weren't achieving the target. And the doctors said, can we increase to 2 grams 8 hourly? So I went away and I popped all the data into IDODS. This was a 45 kilo patient, 175 centimeters, 85 kilos. You can put if the patient's on renal replacement therapy, which this patient was. You have to enter some data. So the first bit of the table is what he was actually on. And then after that, I've just simulated a couple of regimens. So the dose that the patient was on was 1 gram 6 hourly. And then I've simulated 2 grams 8 hourly as a 30-minute push, and I've simulated 2 grams 8 hourly as a 4-hour infusion. So if we have a look at before I get to the cool graphs, the question I always get asked is, when you're doing these simulations, how much do you have to know about the model? And we heard a lot about that just in Dr. Nusaibah's talk. So does the model matter? Well, yes and no. For this patient, you know, the model really should just be able to find the TDM data point and fit it on the concentration time curve, which I'll show you in a second. If this patient was on hemodialysis, they need a specific model to account for that, because there's changes in the PK parameter over a dosing interval, and the models that don't understand that, they just average out the PK parameters over the dosing interval. But if you've got obvious changes in those PK parameters, you need to have a model that can account for that, and you can give it the information it needs to do that. Children should probably have their own PK models, maybe ECMO, because there's some difference in the clearance and volume distribution over the first 2 days. Again, similarly to what's been mentioned before, it's ideal to have some local data, but I do find that often if you need to use a slightly different model to your patient, so if you need to use an obese model in a non-obese patient, if you need to use a model that didn't quite include the age range or the comorbidities, it's okay provided the drug concentration fits nicely on the concentration time curve. If the model's a bad fit, then it's really hard to use it and find that the data are robust. If it's a good fit and you can rationalize why, you know, it might look a certain way, then it's going to be okay. If you're using dosing software without TDM, so you're using dosing software to predict the first dose, for example, or if you're not going to do TDM, then the model and covariates become much more important. The way we tend to use dosing software in practice is with a TDM. So we do a drug concentration, and then we use that in the dosing software and simulate new doses to see whether that achieve our targets. It's a very different situation to be using dosing software for the first dose, and the population PK models have to be a lot more accurate in that setting. And the other thing to say is we are starting to experiment with drug concentrations in non-blood, so in CSF or in joint fluid, and you can't really use those in dosing software at the moment. The dosing software are really only for blood concentrations. All right, so back to our patient. We were able to use dosing software to model the 3 different meropenem doses. So the first set of peaks and troughs here reflect the 1 gram 6 hourly dose. And so that was the dose the patient was on. The little bullseye here with the yellow ring is the TDM, the drug concentration of 1.7. And the dosing software tells me that the time that the free concentration is above the MIC of the pathogen is only about 66% with this 1 gram 6 hourly regimen. Then you can see with 2 grams 8 hourly is a 30-minute push. The concentration time curve reflects this really high peak because we're giving a big dose as a push. And then because this patient's got great clearance and the drug's got only 2% protein binding, it clears really quickly and it actually falls below the MIC again at the end of the dosing interval. So increasing the total daily dose from 4 grams a day to 6 grams a day actually hasn't changed that much about the time that the drug is above the MIC of the pathogen. It's just gone from 66% to 70%. But you can see that when I simulated 2 grams 8 hourly over 4 hours, we bring that high peak way down. So maybe there's less risk of neurotoxicity. And we've shortened the amount of time that the patient has to clear the drug because now they've only got 2 hours to clear the drug. And so it's actually staying just around the MIC at the end of the dosing interval. So then 2 grams 8 hourly over 4 hours achieves 96% of the dosing interval above the MIC, which is really, sort of much better than giving 2 grams 8 hourly over 30 minutes. So the question the doctors asked us was, is it appropriate to give 2 grams 8 hourly? And it is appropriate to give 2 grams 8 hourly, but for these drugs where we know the pharmacodynamic parameter is time above the MIC, we have to also think about how we're administering them, not just the total dose we're giving. Okay, and then my favorite drug, and the next drug I'll just go through an example, is vancomycin. So this is a young male in ICU after an accident. He had a gram-positive cocci in blood, only 16, 75 kilos, and had no kidney impairment. He was given a vancomycin dose based on his weight of a 2.25 gram loading dose, and then was given 1.25 grams 12 hourly as a maintenance dose, working out as about 15 milligrams per kilogram. So our targets in Australia, we're trying to target an AUC24 ratio of 400 to 600, just ignoring the MIC for now, or a trough around 15 for the sites that can't do AUCs. For this patient who was in ICU with a gram-positive cocci in his blood, his first trough concentration was 5 milligrams per litre, which is too low. At the Hurston Infectious Diseases Institute, similar to Dr. Nusaibah, we are developing our own dosing calculator for vancomycin. So this is the Heidi dosing calculator. At the moment, it uses a 1-compartment model from Bualga in 2005. You enter the data, so he had a creatinine of 56, he got the loading dose, maintenance dose, and you enter the first concentration. And then what you can see here is really sort of exactly how dosing software works, which is that the blue line is the population average pharmacokinetic model. But then once you add the therapeutic drug monitoring result or the drug concentration, you can get an individualized PK model based on your patient's PK parameters, and then you can do a lot more accurate simulations. So that you can sort of imagine that our patient in ICU who's young is going to have faster clearance of the drugs than the general PK population that is shown in blue. So that's why the black line is a bit lower than the blue line. So the doctors wanted to increase the patient's dose to 2 grams 12 hourly. And so we've put that into the dosing software here to see whether that would be appropriate. And you can see that even increasing from 1.25 grams 12 hourly to 2 grams 12 hourly, the trough concentration only increased to about 8, and the AUC was still below 400. And then interestingly, the doctors did that, increased to 2 grams 12 hourly, and he did indeed get a trough concentration of 8. So then they said, okay, we need your help. And we said, all right, for this patient, let's start a continuous infusion of 5 grams. And again, the population prediction is in orange, the individual patient prediction is in purple, and it suggested that if we started a 5-gram infusion at the end of the administration time, so not at the next time the dose was due, at the end of the infusion, start a continuous infusion, you should get a steady state concentration of vancomycin of 22. And that AUC is very robust with an AUC of 540, so well within that 400 to 600 range. And that's indeed what we got. They started a 5-gram infusion and then got a drug concentration of 23. Also, that allowed us to think about potentially even dropping the dose a bit more, and we ended up on a 4.5-gram continuous infusion with a steady state concentration just over 20, and the dosing software telling us that that would have an AUC 24 of 485. So I just think, for this patient, how would dosing software have helped? It would have decreased the time that this patient had subtherapeutic concentration. When we went from 1.25 grams BD to 2 grams BD, that dosing adjustment really, it felt like the right thing to do because that's what we've traditionally done, but actually would have been better just going to a continuous infusion straight away. And then actually we could have achieved our targets with a lower total daily dose. And I think the staff enjoy having something to help them make these difficult decisions in these patients. I'm just going to skip over that because I know there's lots of questions. I do want to just quickly touch on the limitations of dosing software. So it does need to be a good fit. Your drug concentrations need to fit snugly on your concentration time curve. Otherwise, essentially, whatever's happening, the PK model is not finding the individual PK parameters of your patient. And so any sort of predictions it makes will be off. Always check your own data entry. And again, sort of a repetitive theme, clinicians still need to be thinking about changes in organ function. The dosing software only knows what you've told it, as opposed to thinking about these AI models. Dosing software isn't going to predict an AKI. So if the creatinine changes, you need to redo your calculations in the dosing software. You can't ever rely on the computer to be a clinical review, for dosing software. Maybe you'll be able to in the future with AI. It's always good to still have the med safety implications. So still have min and max doses that you are comfortable with, because the dosing software will work out doses that will achieve your target, but they might not be safe. And then, there's just some tips about thinking about when is the best time for sampling. If there's lots of samples over time, they can actually be harder to fit as opposed to just different time points within one dosing interval. And the more complicated the models are, they can be very slow to run in practice. Okay, so what I've learned with dosing software is that the POP-PK models are not always useful before you've got a TDM. Empiric dosing can still be sort of just done clinically. Very useful if the target's complicated to calculate IG AUC. Really good for dose adjustment. Always have clinical oversight and make sure you've got a friendly interface. And just quickly to touch on the AI calculators, some of our vancomycin now is moving away from dosing software and moving towards AI models where they find nearest neighbours and start to predict dosing that way. And actually that's turning out to be very effective as well. So it'll be interesting to see where it all goes. And then I'll finish there and hopefully we've got time for a few questions.
We're gonna give the questions later on after this. So we're gonna summarize all the questions and we're gonna pick a few. All right. Thank you so much, Dr. Amy, for the insightful and very comprehensive review on MIPD integration into the clinical practice. We're going to move on to Q&A, our favorite part. So we've got a few questions. With the interest of time, unfortunately, we can only address few questions, and we'll try to sort out with the remaining questions if our speakers can actually provide the answers to us and we email to you later on. So I have the first question here for Dr. Ain. So the first question would be, since we have identified several barriers in applying precision dosing, which do you think should be our main priority to address at this stage?
Okay, we have to develop, we have to have that drug measurement in place in our country, yes. But I know it will take time to set up, because it's not easy. And then, but it's possible actually to have them. But while waiting for that, we still can do the dosing individualization. So I think to do that, is actually to just back to basic, because at the end of the day, when you do dosing modeling, okay, population PK, they are actually back to basic because they put in back all the patient characteristics. You identify the patients, the covariates from patients to fit in the model so that it can be used from that populations, right? And while we have that, we can do that manually by integrating clinical data and the relevant clinical monitoring or parameters that we have in our settings. And another thing about developing this population PK, I really think that is good. I mean, we can have the nomogram or whatsoever, but I think it is required to have our own PK from our patients to embed into this population PK data, then it will be more relevant for us to have the dosing software, dosing nomogram, then we won't have any issue. So as long as we still, adapting population like dosing nomogram from which is developed from other patients, it might be not really fit to our patients, because we have to know the basic of developing this modeling. They are actually putting in the characteristic, right? So it has to come together. We need to have that in our country, because people already advanced. Yes, drug measurement will give you some confidence that you are doing right or not. So we need to have that. But while we have that, while we're waiting to have that proper in our country, we still can do that individualized dosing. Yeah.
Thank you. Okay, we have another one question for you. Considering that renal dosing recommendations are based on manufacturer-derived nomograms, which were developed from their specific study populations, do you think these recommendations remain reliable across different clinical settings? Should we consider validating the nomogram in our own patient population?
I don't think so. You need to validate, because you know that when you know the nature how the nomogram being developed, because they may exclude certain population. Of course, when you wanted to apply that to a specific population, it will be not really accurate, right? So until you have the integration data from other population, which is a thing that has been not only a discussion here, but has been widely discussed, that the standard dosing from the company, they rarely include the special populations such as the critically ill patients. That's what needed, meaning that they have to integrate, the PKPD dosing, and that will be better. Apply to every populations, right? So yeah, I think as long as you don't need to validate whatever that being established from population, we need to have development of proper dosing that inclusive of various patients. Yeah.
Thank you. Thank you very much. My next question would be for Dr. Nusaibah. Okay, Dr. Nusaibah, there are different MIPD models derived from varying study cohorts and assumptions. How should we select which MIPD software to start with and which model to use in our center? And how should we decide? Well, okay, there are many questions in one go. How should we decide whether we should rely on published models, population PK models, or locally?
Okay, yeah, that's a really great question. Yeah, so when you look at the MIPD tools that are available, for example, the table that I shared, the 10 MIPD tools, so it's worth looking at it and looking at what sort of drugs that are covered. So to answer your question, you would have to ask, what sort of drugs and what sort of models are available on that software. So that's how you would differentiate the products in a way. Okay, so maybe some covers say 5 drugs, another covers 20 drugs. So you would want to look at those tools, and then you would want to also look at the models, and then whether or not it captures your population that you wish, to get that precise dosing for. Yeah. Sorry, Fikree, what were the other questions?
How should we select which MIPD software to start with?
Yeah, so I guess that answers that in terms of the tools that are available. Yeah, so as mentioned, you would have to look at each of the product. But again, as mentioned, one of the challenges is the cost itself. So not just about, what sort of antibiotics or drugs that they cover, how much are we talking? So that might also be a consideration in terms of selecting the MIPD tool or software.
We have another question here on the prototype product which you are currently developing with your team. By any chance, is it still open for beta testers by other pharmacists?
There you go. Nice. Yeah. So, with MIPD, and when we talk about pop PK models, like I said, we really need to develop more. We're not at a stage where we have that yet, right? So, of course, we're very open to more collaborations in terms of getting more, looking at more data collection from our local hospitals, as well as, building more and, evaluating and validating more pop PK models that can then be fed into MIPD tool. Yeah, so definitely very open still. Yeah.
Okay, perhaps the last question for you. For practical clinical use, what is the minimum data requirement to apply MIPD guided dosing?
Minimum data. So I guess I'm not too sure what you mean by minimum data, but when we have the tool, so basically we have the input, right? So if say you have a concentration that you get from TDM, then you can put it in. So because we're talking about Bayesian, then one is technically sufficient, one concentration. But of course, when we talk about modeling, the more you have, the better. So like not to say like one is enough technically, but two would be better, right? Yeah. So in terms of that, but technically one concentration is sufficient.
All right, thank you. Okay, we're going to move to our third speaker, Dr. Amy. So the first question would be, if we in Malaysia intend to initiate beta-lactam TDM, what would be your advice on where to start in terms of implementation and priority patient groups and the minimum lab and clinical support required?
Yeah, it's a great question. We find our beta-lactam TDMs really useful, but we actually don't do that many. So you should really have a look at why you're thinking about implementing it. So it's obviously the patients that we tend to do it in our ICU patients who are worried about low concentrations because the therapeutic range is so large for beta-lactams that even with high concentrations, you often don't see toxicity. So the main reason you're going to be doing it is because you're particularly worried about low concentrations. Now, in Australia, we have very low rates of resistance, particularly in our gram-negatives. So we haven't had to do a lot of pushing the dose. But particularly if you were in an area where you had a lot of resistant gram-negatives, or whether you wanted to be making sure that you could dose into that susceptible dose-dependent range, that would be, for me, a really useful way to have a priority target of patients where you're worried about poor outcomes. You want to start doing, extended or continuous infusions, and you want to make sure that you're hitting your targets you want because of difficult to treat pathogens. So I think there's been a few ways of doing it. So we have a really stewardship-based approach to our beta-lactam TDM where we only do it if there's a need. There are other sites. There's a site in Melbourne, and Dr. Nusaibah might be able to speak to this, but when they implemented their beta-lactam TDM, they just did it in every patient. So in every patient who was starting beta-lactam in the ICU, they did TDM, and they found that the patients they hadn't thought of needed adjustments, and it really helped their learning and their experience. We decided to make it a bit more of a hub and spoke model in Queensland. So you only ask for it for the patients you want, but we service a huge area. And so it's, for the lab, they want to be doing lots of assays, because you don't want to only be doing 1 or 2 assays a year, or you'll lose your validation for your assay. So if you're going to be doing it the stewardship way, it's good to be able to service lots of different hospitals and have a model where you could do it that way.
Okay, thank you. My second question would be, how do you resolve or judge when the models seem not in a good fit, since the model might be developed with population different from the targeted ones, i.e., like for example, US pop data for an Asian population?
Yeah. So the number one way that I do it is by checking that my drug concentration fits snugly on the concentration time curve. If I also do a little bit of visual inspection, like, having done it quite a few times now, you want to be able, is the peak on the graph what you expect? Is the slope of the concentration line what you expect? If you've got a patient who you think they've got augmented renal clearance, you should be seeing, a high peak and then a really skinny AUC, coming down, reflecting that really fast clearance. So you can do a bit of visual inspection on the graph. And you can also, use this is the beauty of being highly skilled without TDM. It actually is a huge benefit to have we're losing some of this, where we've got some of our pharmacists are really reliant on TDM and dosing software. And it's a real shame, actually, because the skills that we all have from not having it and having to make these decisions without it make us really good clinicians. And we don't ever want to lose that. Sorry, that was a bit of an aside. You really, the fit, I don't think it's such a huge sin to use a model that's not perfectly aligned to your population, provided it's a good fit. And by a good fit, I mean that the drug concentration fits on the concentration time curve. The concentration time curve looks as you would expect. And then if you are making that leap between your population and the model and they're not exactly aligned, then you want to be thinking, I need to recheck. I need to make a reasonable decision within, I'm not going to go to 10 grams a day of vancomycin. I'm going to, again, still think of what a reasonable dose is. And then because there's a slight mismatch, I'm going to recheck within 48 hours. And you do have that flexibility with dosing software because you haven't got to wait for steady state. You can check to see, is my prediction right based on the graph I've developed, as opposed to, am I at steady state? And this is a robust TDM that's going to continue on for the next week. Having said all that, there are some absolute no-nos, which is, you can't have a patient who's going on and off hemodialysis on a non-hemodialysis model because they just can't account for that. But this is more like if an obese model fits your patient, but your patient's not obese, I'd be okay with it, provided the concentration fits on the line. And sometimes that can be explained by the hyperdynamic circuit of our critically ill patients, and they fit the obese model because they also have a component of hyperdynamic, circulation.
Wow, thank you. Definitely, we have a lot more to learn from you. Well, anyways, I think that's the end of our Q&A. I would like to thank you to all our speakers, Dr. Ain, Dr. Nusaibah, and Dr. Amy for such a valuable insights, and to all participants for joining us this evening. On behalf of MySPARK and MyICID, we truly appreciate your time and engagement. We hope this session has provided meaningful perspectives on improving antimicrobial dose optimization in Malaysia and beyond. So before we conclude, we kindly invite everyone to scan the QR code, the participants, which is displayed on the screen, to complete the post webinar survey. And we're gonna email your e-cert in a few days to go. So please stay tuned for future events from MySPARK. Again, I would like to thank everyone for the commitment, for the time made during the weeknight. Wishing everyone a pleasant evening, and thank you again. Assalamualaikum and good night, everyone. So to all, whoever our panelists are still here, let's take our group photo. Adam, I don't see you.
I'm
Dr.
not on my
Helmi,
laptop.
Dr. Helmi.
Dr. Helmi.
Oh,
Wong
he
Ijing.
just left.
Belum sih.
His pillow called him already. While Amy is still with us.
It's 11:30 and I feel more alive than ever.
Adam, aren't you gonna open your camera?
No, I'm not on my laptop. And I don't have the background, so
Oh, it's fine though.
it's okay. It's okay. I'll be excused for tonight.
All right. Okay. So I'll take the smile, everyone. Okay, 1, 2. Okay, another round. Just in case the first round isn't going well. Okay. Space. A small love. All right. Thank you, everyone.
Thank
Thank
you.
you.
Congrats, guys.
Thank you.
Thank
This
you,
is
everyone.
indeed a very, I feel this is very enlightening. Especially, actually, I had like worried and concerned whether is this topic is gonna be very, very heavy for us. But unfortunately, the three of you make it very, very uplifting and easy to comprehend. Thank you so much.
Girl power.
Glad to hear that. All good.
Thank you.
Thanks,
Bye.
guys.
Bye, Amy.
Bye. Thanks again,
Bye,
Amy.
everyone.
Thanks,
Take
guys.
care.
See you back
Bye,
again.
Amy.
You again.
Bye.